Hi, welcome to my 8th video on the economics of intimate partner violence. Well, this might be my last video, or maybe I might have another video after this. Well, we were left with the Hymantes article's last result, which basically has showed that the women who were subject to the intimate partner violence were more likely to make their husbands to control the income they have. This actually shows, maybe is showing something. In a traditional society, at least, this might not be true for all societies, and we have already seen in the first article. The asset-rich woman, intimate partner, the employment might be something that might reduce the intimate partner violence inside of the house. However, the for the woman who might not, for whom the employment might not let them get that threshold, well, that employment might still be desirable for them for different reasons. Maybe because they cannot trust to their husbands. Maybe at least that employment and the money gives them some privacy, basically. But at least, at least we might say from this study, these studies are showing significantly for some traditional societies and for some low-income groups, at least, or maybe in some traditional societies, even for the middle or high-income groups. Employment and earnings doesn't necessarily reduce intimate partner violence. While intimate partner violence might be a tool or very much related to actually it's something that might be even exerted on the woman who might be working. And basically that exertion, note that when for the woman who had experienced intimate partner violence for the last 12 months, it's the husband's control over the resources is much more likely. It increases from 15% to 17%. It's not decisive, but it increases the possibility a lot. This means actually intimate partner violence might be a tool, even in the families where the women are working, to get that particular resource women themselves have earned from them, or at least have more control over that income. So basically, it might be a tool which might basically even be effective in on the control over the economic resources within the family, maybe. But for the most families in India, by the way, 62% and 64%, the women who have women and men have control over the earnings earned by a wife. But note that these are the earnings that are earned just by the woman, not by themselves again. And only around 20% of the women have control over the resources, earnings they have themselves have earned. And between those two groups, there is the intimate partner violence doesn't have any significant effect. So intimate partner violence actually is only effective to actually let the woman not to say anything, anything on the money they themselves have earned. Anyway, these are the studies on the intimate partner violence. Last study we will look at is not on the intimate partner violence, but rather on the access to health. And here we are looking to the Rwanda, basically. Where is Rwanda? Rwanda, you might have heard Rwanda actually. It is a place where a genocide has actually occurred in recent history. And there was a movie on it also. It is somewhere around here. That's right. So, Rwanda is the Turkish version of it. And it is right next to Congo, and Tanzania and Uganda actually is above it. Well, the country has experienced a genocide and then civil war, which has killed many men in the families. And it was actually a intercommunal type of civil war, not a civil war between just the factions of government forces, which means actually the killings were much more severe because now the people are enemies of each other and kill each other. And basically, after the war, in order to improve the healthcare conditions, especially of low-income people, especially in the rural areas, the state has implemented a program called community-based healthcare program, well, basically the families who there is actually possibility of getting private insurance in Rwanda. However, there are significant number of people who did not have access to that government-based the private health insurance programs. So, community-based health care program was basically implemented to make people who have less access to those private insurance to have access basically to the healthcare. The study actually is testing who has actual access to this program, and it finds actually, even though in some sense rural, at least in the rural areas, opposed to cities, where private insurance, access to private insurance is less, the access to CBH, community-based healthcare program, is higher. The families who are headed by the females have less access to the program. And note that, well, in most of the countries, female-headed households are not much in number, but in Rwanda, because of the civil war, many men has died, so the number of the female-headed households is not that much, that small in Rwanda. There are significant number of basically women who don't have access to them. Who are head of the household. And basically, well, you can see actually from the basic numbers, there are 88 men up for the 100 women. Maternal mortality is 775 per 100,000 births, which basically means that from every 1,000 childbirth, in every 1,000 childbirth, more than 7 women are dying. Under 5 child mortality rate is 152, which means out of every 10 children born, 1.5 of them will die before they got age 5. So these are the reasons why the private insurance is considered is not be enough by the country. The country decided to implement a governmental program, basically. Let me open the article. Oh, I'm sorry. The article is already opened here. Okay. So here basically you see in the table 2, and the name of the health insurance is actually called MHI. Well, MHI basically means that mutual health insurance, and that's the name of the community health insurance we were talking about. And here we are looking to the different income quantities and basically, well, total access of the health insurance by the people who are in those quintiles. And as you see, all the way up to the fourth quintile, the access increases, which might be surprising because the richer people have more access to that insurance. Well, maybe in Rwanda, the situation might be so bad even up to all the way to the richest quintile. People might be struggling to get health insurance, but the people at the higher income quintile may also have more connections, which might help them to get the health insurance, mutual health insurance. The richest quintile, in the richest quintile, the ratio has fallen, although not as low as the second and first quintile. A significant percentage of the richest people also have mutual health insurance. Well, there might be some people, of course, in the richest quintile who might have some private insurance, basically. Well, in the male-headed households, it is like this. The trend is same, but ratios are different. In the female-headed households, interestingly, all numbers are lower. 44% of the male-headed households in the poorest quintile, for example, have the mutual health insurance, while in case of female-headed households, it's 21%. In the highest, the income group with the highest ratio of mutual ratio of people who have mutual health insurance is the fourth income quintile, where for the male-headed households it's half, 50.2%. For the female-headed households it's 38.3%. So in total, you might see that 39.4% of the population has the mutual health insurance. Although I don't know, the 84% of the people. Well, probably these total numbers. I mean, they don't add up. So don't take into account these total numbers. These these are actually okay. In total, 39.4% of the people have the mutual health insurance. But these total numbers are basically, if you add them up, you can find it. 15.7% of the people have a female-headed household, but 84.3% of the families have a male-headed household. Low, but still higher than usual, basically, female-headed households. So next, we will look to two different regressions. The one of them is looking to the membership of MHI. And then we will also look to the access to the healthcare, the use of the healthcare facilities, basically, and what are the factors that are affecting that, and whether being a female-headed household is affecting that negatively, specifically, in addition to the penalty that might exist. We will also look to that in membership of MHI. So we are coming to the end of our 15 minutes, so we will basically see the results in the next chapter. So see you in the next part.